So welcome to Thrombosis Canada's Highlights from the American Society of Hematology 2023 Congress, Canadian Perspectives. In this presentation, we'll go through important research in thrombosis and hemostasis presented at the ASH conference in 2023. So my name is Jameel Abdulrehman. I'm a hematologist in Toronto, and I'll be sharing this presentation. Here are my disclosures. I received speaking honoraria paid to my research institute, and also research funding. And I'm delighted to be joined today by these excellent speakers, Dr. Lana Castellucci in Ottawa, Dr. Ali Mead in Vancouver, and Dr. Alfonso Iorio in Hamilton. It's important to note that this program has received support from Pfizer Canada in the form of an unrestricted educational grant. Pfizer had no input into the content of this presentation. This program has received no in-kind support. There's potential for conflicts of interest in that the speakers are eligible for an honorarium from Thrombosis Canada, and Pfizer benefits from the sale of a product that may be discussed in this program. The content of this program was developed by the faculty and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. This is a Royal College accredited activity. The overall learning objectives for this presentation are to discuss highlights of key thrombosis and hemostasis related presentations from the ASH 2023 annual meeting. Here's the agenda for today's presentation. The speakers will go through the highlights from ASH, then there will be a Q&A, and finally we'll conclude and wrap up around 8:30. All right, so I'll pass it on to Dr. Castellucci.
Thank you, Jameel, and hello, everybody. Just going to get prepared here. So it's great to be here, and thank you to everybody who's joining us. My name is Lana Castellucci, and I'm a thrombosis physician in Ottawa. And the abstracts that I'm going to talk about today are related to cancer-associated thrombosis. Before we get there, these are my disclosures, none of which are relevant to today's presentation. In terms of learning objectives that I really would like to cover for today, we want to talk about identifying limitations for current risk assessment models for cancer-associated thrombosis and identifying independent risk factors for VTE in patients with specific cancer types. So looking at patients with lymphoma, as well as those independent risk factors among patients with cancer in sort of an ongoing dynamic modeling type of analysis. And we'll begin with a case. So this is a 65-year-old woman who has a history of diabetes, and she's recently diagnosed with stage 3 diffuse large B-cell lymphoma. And a few weeks ago, she had been hospitalized at the time of her diagnosis. There's no personal history of VTE and no history of bleeding, which of course is relevant. Her ECOG status is not great. She's had difficulty with ambulating and is severely fatigued after her hospitalization. She has an elevated BMI of 40, and her CBC is listed there. So white blood cell count of 15. She's anemic at 100, and platelets are okay at 300. And she's about to start our CHOP therapy. And because of her cancer status and some of her other parameters that are listed here with elevated BMI and elevated white count, you're asked to see her and determine if you would consider anticoagulant prophylaxis for this patient. And we'll talk about what is the risk of cancer-associated thrombosis. So this information comes from a large database on U.S. veterans from 2006 to 2021. And they looked at what the VTE risk is over a 12-month period in U.S. veterans over this entire cohort of patients with all types of cancer. And what you can see here is on the left-hand side, we're seeing that patients are particularly high risk of VTE with certain cancer types. And we already know a lot of this. So pancreatic cancer, certain types of brain tumors, as well as gallbladder and biliary tree cancers. And then, of course, important for our patient in this case is non-Hodgkin lymphoma, that is aggressive subtype. And then gastric cancer and esophageal cancer fit into that as well. The dark green bars are overall VTE rates over 12 months, and then the lighter green is PE or lower extremity DVT over a 12-month period. And what you can see here is that this is, of course, in patients that are receiving systemic chemotherapy. And in the top right here, we're looking at the time horizon from 2006 to 2021. And you can see that the rate of VTE is pretty consistent between 4 and 5% over that entire time period. And so that's a reassuring thing that it's consistent. And then one of the things that we, of course, want to try to determine is what is someone's risk of cancer-associated thrombosis. And many of you are familiar with the Corona score, which is what we use to help determine that risk. And this table highlights the different components and variables with a score attached to them that help us determine what one's risk is. And as we know, the score is 2 or more points to be determined high risk for VTE. And so if we look at our patient and we go back to what type of cancer she has an aggressive diffuse large B-cell lymphoma, which doesn't meet our very high risk or high risk tumor categories. It's more of a moderate risk, so it doesn't get a point. But she did have an elevated white count of 15. Her pre-chemo hemoglobin was 100, so that doesn't get a point. Her platelet count was fine at 300, but she does have an elevated BMI of 40. And so using the white count and the BMI, she would get a score of 2. And so we would use that as a method to help us consider whether or not we would prescribe prophylaxis. Most of us are also familiar with these 2 randomized clinical trials from 2018, and this is a nice meta-analysis looking at these 2 large RCTs. The first one was the AVERT trial, which evaluated ambulatory cancer patients that were determined to be high risk of VTE using the Corona score of 2 or more. And they were randomized between apixaban 2.5 milligrams twice a day or placebo for 6 months. And the other trial was the Cassini trial, again, ambulatory cancer patients, high risk with a score of 2 or more, and randomized to rivaroxaban or placebo for 6 months. And all of these patients were evaluated just prior to starting chemotherapy. And patients that were deemed high bleeding risk were excluded. So we are looking at a low to moderate bleeding risk population. And when we synthesized the data and put it together, there were nearly 600 participants in AVERT and just over 800 in Cassini. So when we look at this cohort of patients and we try to evaluate their incident VTE rates over 6 months, we can see that there was a substantial difference. So using prophylaxis resulted in a rate of 5% over 6 months compared to 9% in the placebo group. So a 45% risk reduction. And then, of course, we want to evaluate what the bleeding complication and safety rates are over that 6-month period. And these numbers are small. So for those in the placebo arm, we know that patients with cancer are at risk of bleeding. And so their risk is 1%. And for those that were randomized to an anticoagulant, it doubled at 2%. So the absolute number is small, but from a relative perspective, it is a doubling of risk. And next, I'm going to talk about another meta-analysis that was done, which is a slight bit more comprehensive. And this is evaluated and discussed in the ASH Cancer-Associated Thrombosis Guidelines published in 2021. And this is talking about the 2 studies that I just presented, AVERT and Cassini. But there was also a very small phase 2 trial done many years ago, and it was published in JTH in 2012. And it was the phase 2 trial evaluating different doses of apixaban in this similar patient population of ambulatory cancer patients that were deemed high risk of VTE. And so that combination of 3 trials, again, demonstrates that the rate of VTE in patients who are on placebo or not receiving any prophylaxis is high at 9%. And the bleeding risk, if they are on anticoagulants, is about 2%, which is all consistent with what we saw in the previous meta-analysis. And so going to the 2021 guidelines from ASH, what they state is that for ambulatory cancer patients at high risk of VTE, once they start receiving chemotherapy, the panel suggests thromboprophylaxis with either apixaban or rivaroxaban over no thromboprophylaxis. And this was a conditional recommendation with moderate certainty of evidence. And the classification of patients as being low, intermediate, or high risk should be evaluated using a validated risk assessment tool such as the Corona score, as well as using our clinical judgment and experience and expertise. I would also add in there that patient values and preferences is something that we obviously need to consider as well. And many of our decisions also need to factor in financial constraints, because this would not be using these medications in terms of what's directed in the product monographs. And so there may be an additional cost to patients to use these medications. And so next I'm going to talk about what all of that information means. So from that introduction, we know that there are still some unanswered questions about patients with cancer and what their risk of VTE is. And what we'll talk about next are two abstracts presented at ASH. And one of them is looking at pan-cancer models, looking at specific lymphoma patients, with the rationale being that pan-cancer model risk assessment scores such as the Corona score may not be as relevant to patients with lymphoma. And then the second abstract is looking at something called dynamic modeling, which is a regular reassessment of an individual person's risk for VTE. And so we'll get into this. So the first abstract is titled Development and External Validation of a Lymphoma-Specific VTE Risk Assessment Model. And this was led by Dr. Lee's lab in Texas at MD Anderson Cancer Center. And we'll just jump into the methodology. So they had a derivation cohort and a validation cohort. These were three different health systems that were used. And the derivation cohort was using the VA cohort. And this is obviously a unique patient population. So VA hospitals are government-funded hospitals, and they had 10,000 patients with lymphoma that were starting systemic chemotherapy. And these were patients that were retrospectively identified, of course, and receiving their first line of chemotherapy within a year and had not had previous history of VTE or anticoagulant use. And they used 30 different predictors that were based on demographics, lab evaluations, and different ICD codes. And they went through a series of analyses to come up with a model that used 30 clinically relevant risk factors that they ultimately tried to validate in two separate cohorts. The first cohort was in 854 patients in Harris Health System, which is a county hospital in Texas. And then at the MD Anderson Comprehensive Cancer Center, they looked at nearly 1,900 participants. And so when we get into the nitty-gritty of their final model, this is what it looks like. So in these lymphoma patients, they evaluated them according to risk based on their histology. And the low-risk group is the reference group. So it's this line here. And intermediate, high risk, and very high risk are delineated here. And if we go back to our patient case, she had diffuse large B-cell lymphoma. And in this categorization model, she would be high risk. What else they included were things that are familiar to us. So the BMI being elevated above 35, cytotoxic chemotherapy, history of VTE, history of prolonged hospitalization of more than 3 days in the last 3 months, as well as history of paralysis or immobilization, and time to first treatment was considered as well. And the reason that these are highlighted in red is that these are relevant to the case that I presented at the start of my presentation. And so what they determined or identified to be high risk were a prediction of greater than 7% at 6 months of developing VTE after starting systemic chemotherapy. And they went on to compare this new model to the existing Corona score to see if there was a difference in each of these patient cohorts. So in their derivation cohort using the VA population, in blue line is the new model, and in the orange, it's the old Corona score. And what you can see here is that there is, in fact, a difference. And so a difference that was relevant in terms of the threshold of high risk of 10%. So with their new model defining high risk above 7%, it meets the threshold of what the ASH guidelines recommend as well. You can also see that there's a difference in the C statistic in that it's better delineated with the new model of 0.68 compared to using the Corona score of 0.57. And this goes out across the different months of chemotherapy. And then when you look at the validation cohorts, again, this is a consistent trend where the C statistics were certainly higher using these new models compared to the existing Corona score. And so better prediction perhaps using this new model. Having said that, there are some challenges with these new models. Yes, they did predict that for lymphoma patients, the existing Corona score may not be as good as this new model, but it is a novel model that, although validated, it was validated retrospectively. And so that's a limitation whenever we're looking at risk scores. We want to try to validate them in a prospective cohort. And then some other limitations are related to the diagnostic components of the lymphomas in terms of flow and molecular markers that may change one's risk, as well as some key patient factors in terms of their performance status. And so is there immobilization factored in? And if it was factored in, would that modify your risk? And so if we go back to our case of our 65-year-old lady, at this point in time, she's completed her R-CHOP, but unfortunately she had a relapse a little over a year later. Once she's been restaged, there's a decision to proceed with salvage therapy, and her ECOG status remains poor at 2. Her white blood cell count is 17. She's anemic with hemoglobin of 90, and her platelets are 200. She also has an albumin of 30. She did not receive thromboprophylaxis during her first therapy and did not develop VTE. And so now that we know what we know about this new risk model, the question is, would you prescribe this patient pharmacologic VTE prophylaxis using either apixaban or rivaroxaban? And so I think the information we have today is certainly intriguing, and it definitely makes us think about these cancer patients differently based on their cancer type and other risk factors. But I don't know that right now we have enough information to make a decision and recommendation for our patient. And next, I'm going to move on to this second abstract that's called Dynamic Modeling for Cancer-Associated VTE. And this is led by Jeff Swicker's group in New York. This is a really interesting design where they looked at 12,000 patients in their solid tumor cohort. So they have an existing database, and their index date was at tumor sequencing, not at initial diagnosis. And they randomly divided this patient cohort into the derivation group and the validation group. And they looked at predictors over 1 month time periods to try to determine on a recurring basis what one's VTE risk is. And the predictors that they used are listed here. So age, cancer type, time from diagnosis, and the usual labs. So CBC, renal function, albumin, as well as chemotherapy agents that were used. And they used something called Bayesian dynamic multivariate modeling. And they were following patients over time. And with their risk predictors, specifically looking at the different cancer types and histology, what you'll see next to each of these is an arrow. So obviously the upward pointing arrow means an increased risk, and anything downward pointing is a lower risk. And they did this according to cancer type, cancer treatments, as well as lab variables. And as I mentioned, on a recurring basis, they would run these models every month to try to determine what one's risk of developing a VTE is in the subsequent month. And when they used their logistic regression modeling, they saw that there was, in fact, a slightly better C statistic using this dynamic modeling compared to the static modeling, which was, again, using the Corona score at a single time point. And so this is a really interesting way of looking at one's risk. And with AI, there's going to be a lot of opportunities for us to continue to see how this evolves. What they concluded is that dynamic modeling in solid cancers could improve accuracy of VTE risk determination, and incorporation of these deep learning methods may improve model performance. Of course, again, there are some limitations in that it's a complex methodology. There was some missing data, and of course, external validation is required. And next, I'm going to turn it over to Jameel. So thank you, everyone.
Perfect. Thank you. Great. So in this next session, the learning objectives are first to discuss an approach to anticoagulation in patients with COVID without VTE, in which we will review the ASH guidelines for anticoagulation in patients with COVID, which was presented at ASH by Dr. Deborah Siegel. And second, to describe the increased risk of VTE with double heterozygous carriers of factor V Leiden and prothrombin mutations, in which we will review a large biobank data study presented at ASH by Dr. Justine Ryu. I'd like to thank both Dr. Siegel and Ryu for sharing their slides with us today so that we can go through them in this presentation. So we'll start with the ASH guidelines for anticoagulation in patients with COVID. The guidelines address three major groups. First, acutely ill medical patients. So these are patients hospitalized with COVID. Second, critically ill patients. These are patients hospitalized with COVID requiring critical care. And third, discharged patients, patients who were hospitalized with COVID and now being discharged. The guidelines were created using the GRADE system, which is a systematic and transparent approach to guideline creation. We'll go through a brief overview here of the whole system, and then later we'll look at some of these aspects in detail. So to start, the panel defines well-formulated PICO questions with an emphasis on patient-informed outcomes. From there, the evidence synthesis team conducts a search to identify the best available studies to answer these questions for data extraction and synthesis. For each outcome and for the overall body of evidence, a level of certainty is assigned using the GRADE criteria. All this information is summarized into a evidence to decision table, and the panels use each table to come up with their recommendations. For each recommendation, there's a direction, so for or against anticoagulation, a strength of recommendation, and a certainty of evidence. So here are the outcomes that were selected. The most important outcomes were weighed the heaviest, and those were all-cause mortality, PE, DVT, and major bleeding. In considering the effect of anticoagulation on the outcomes, the methodologists emphasize the importance of absolute effect rather than relative effect. So with each recommendation, we have a certainty of evidence and a strength of recommendation. The certainty of evidence pertains to the quality of the studies that went into making that recommendation, and that's rated from very low to high. Whereas the strength of recommendation is a panel's confidence that the desirable effects of anticoagulation outweigh its undesirable effects, and that was categorized as conditional or strong. So here we have a closer look at how the certainty of evidence was determined. So it starts with the body of studies that went into the recommendation. For randomized control trials, the initial estimate is high confidence. If it's observational studies, the initial estimate is low confidence. From there, variables can increase or decrease the confidence. So for example, confidence can be lowered if there's risk of bias, inconsistency, indirectness, imprecision, or publication bias, and the confidence can be increased if there's large effect or dose response. And then finally, there's a level of certainty assigned, and again, ranging from very low to high. The strength of recommendation tells us how we should interpret the recommendation. So with strong recommendations, for patients, this means most patients would want the intervention. For clinicians, it means most individuals should receive the intervention. Whereas with conditional recommendations for patients, this means a majority would want the intervention, but many would not. And for clinicians, it means different choices will be appropriate for different patients, depending on their values and preferences, and to use shared decision-making. So interpreting the guidelines, we do need to keep in mind the challenges in both the evidence and the recommendation formulation. With the evidence, there were a large number of citations, incomplete reporting, risk of bias, imprecision, and the field continues to evolve. With the recommendation formulation, all of the recommendations are very low certainty of evidence. They do not rely on non-COVID evidence, and the guidelines are living in that recommendations can be reconsidered, and they need to be provided in a timely and stable manner. One of the largest challenges was the imprecision in the rate of VTE across the studies. This may have been a reflection of many of the studies being small and only few RCTs. Many of the studies had a high likelihood of bias. There were also differences in the studies that could have accounted for the difference in the rates of VTE. So for example, differences in diagnosis, did they do screening or only testing in symptomatic patients? Differences in the definition of VTE, did they include distal DVT or only proximal? Differences in prophylactic strategies, and lastly, differences in time. As the pandemic went on, there were new variants and new COVID treatments, which may have affected the rate of VTE. Okay, so we'll move on to the recommendations. So in patients with COVID-related critical illness who do not have confirmed or suspected VTE, the panel suggests prophylactic anticoagulation over intermediate anticoagulation, and prophylactic anticoagulation over therapeutic anticoagulation. This was a conditional recommendation based on very low certainty in the evidence. Because these are living guidelines, updates are coming. The panel is currently working on an executive summary as a part of sunsetting the guidelines. In patients with COVID-related acute illness who do not have confirmed or suspected VTE, the panel suggests prophylactic anticoagulation over intermediate anticoagulation, but therapeutic anticoagulation over prophylactic anticoagulation. And again, this is a conditional recommendation based on very low certainty in the evidence. And lastly, in patients with COVID who are being discharged from the hospital who do not have confirmed or suspected VTE, the panel suggests against post-discharge anticoagulant thromboprophylaxis, and again, conditional recommendation based on very low certainty of the evidence. So the panel acknowledges that these questions are of lower priority compared to earlier in the pandemic due to changes in natural immunity, vaccinations, new variants. The overall burden and severity of COVID is decreased compared to it was earlier on. So it's unclear if the risk of thrombosis with COVID today is the same as the risk of thrombosis with COVID from earlier in the pandemic. The panel also acknowledges the uncertainty of evidence is an ongoing challenge, but emphasizes the importance of individual patient assessments for their thrombotic and bleeding risks when determining the appropriateness of anticoagulation. So currently the guidelines are in the living phase, but are moving on over to the sunset phase. Okay, so next we'll move on to thrombosis risk in double heterozygous carriers of factor V Leiden and prothrombin mutation. Factor V Leiden and prothrombin gene mutations are congenital thrombophilia that are present in approximately 2 to 5% of those of European descent. Heterozygosity for either gene mutation is associated with an increased risk of initial VTE by 3 to 8-fold. Individuals who are heterozygous for both factor V Leiden and prothrombin mutation are referred to as having double heterozygosity or the DH genotype. The challenge is the risk of thrombosis associated with the DH genotype is largely unknown. Previous studies have attempted to characterize that risk of thrombosis associated with double heterozygosity, but have been limited by modest sample sizes, ascertainment bias in patient selection, inability to adjust for confounders, or heterogeneity of included studies in the meta-analyses. So identifying this knowledge gap, the team set out to provide an accurate estimate for the risk of thrombosis associated with double heterozygosity. They used 2 large biobanks in the UK and Finland, which combined contain data on approximately 1 million individuals with longitudinal follow-up, which is regularly updated. Almost all participants in the database have array genotyping data available. So combining the biobanks together, they had about 1 million participants with a total of 44,000 VTE cases. Of all the participants, 662 were double heterozygous. The team assessed the risk of thrombosis in those who were heterozygous prothrombin, homozygous prothrombin, heterozygous factor V Leiden, homozygous factor V Leiden, and of course, double heterozygous. They looked separately at VTE and arterial thrombosis. They combined the data using random effects meta-analysis, and they estimated the risk of VTE using logistic regression, comparing cases to controls. They conducted a secondary analysis after adjusting for confounders. So here's the results. We can see there was a low prevalence of the double heterozygous patients at 0.067%, which was comparable to the prevalence of, the prevalence of double heterozygous was 0.075, which was comparable to the prevalence of factor V Leiden homozygotes. The odds ratios for VTE were 1.86 for heterozygous prothrombin, 3.07 for homozygous prothrombin, 2.28 for heterozygous factor V Leiden, 6.19 for homozygous factor V Leiden, and 5.24 for double heterozygotes. All of these were statistically significant. The team found a slight difference in the UK and the Finland data. So in the UK data, the odds ratio was 4.67 compared to 6.15 in the Finland data. So after adjusting for confounders, the odds ratio, at least in the UK biobank, was 4.53. The team found that male sex and blood group O was associated with a decreased risk of VTE, whereas smoking and increasing age, BMI, and CRP was associated with an increased risk of VTE. In the survival curve with freedom from VTE on the y-axis, we can see the double heterozygous genotype was associated with a greater risk of VTE over time. Because the association between congenital thrombophilia and arterial thrombosis was unclear, the team looked at this as well. They found no association with arterial thrombosis and congenital thrombophilia, including with double heterozygous. So putting these results into context, there were several benefits of the team using these large biobanks. They're able to study a large sample size of patients, including a large group of those who were double heterozygous. The ascertainment bias was mitigated. They could assess a largely homogeneous population. They were able to adjust for common risk factors, and they had less uncertainty compared to prior pooled analytical estimates. So to conclude, this was the largest study assessing the risk of thrombosis in those who were double heterozygous. The DH genotype is rare, and the prevalence is similar to that of homozygous factor V Leiden. The risk of VTE with double heterozygosity is approximately twice that compared to heterozygous factor V Leiden and heterozygous prothrombin, but there was no associated increase in the risk of arterial thrombosis with double heterozygous. Okay, and now I'll pass things on to Dr. Amin.
Hello, everyone. This is Ali. I'm one of your junior pediatrics colleagues. My plan is to present some slides from pediatric studies, and I'm hoping that I chose this studies so that it is interesting for most of the adult audience as well. Next slide, please. I have some membership on advisory boards that you can find it here. There's nothing relevant to the studies that I'm going to present. So the first study that I chose, it is something that we quite often, unlike adults, the population, it is quite a dilemma for us. It is something that we get quite a lot of consults, and 90% of the times we say we don't know what to do really. And that is the dilemma of whether you have to treat in terms of the prophylaxis of any clot in the ICU settings. We have very little good quality data for pediatrics. So this consortium was basically, it's a large consortium based in the US, and this study was presented by Dr. Jaffrey. That intended to look into different aspects of the thrombosis and prophylaxis in pediatric population, taking advantage of a collaborative effort to this. You probably know that in pediatrics, the rate of thrombosis is much, much less compared to adults. So that means that really we have to have a collaborative approach to something like this. Next slide, please. So basically, these are the objectives to describe the development and validation of the risk assessment model in critically ill patients in the ICU, and whether this can be kind of applicable to our population. Next slide, please. So as I said, there is these children with in the PICU, they are in general at high risk of thrombosis formation compared to the other children. This consortium initially aimed to create a risk stratification model. They used the largest 8 centers in the US to come up with a basically some scoring system for the classification. And during many using many different variables, they came up with these 5 variables: basically immobility, the time of PICU admission, whether there's a venous central catheter present, if there's any congenital heart disease at the background, or if there's any autoimmune or inflammatory state or infection. These were found to be the significant factors for the initial risk assessment model. So the intention of this study was to really externally evaluate that risk model that they have created in an independent cohort, much larger cohort that included 32 US centers through this consortium. So here they used data from this 32 US center for over 20 months, for over 30 months, and basically they collected all the data excluding patients who had a recent cardiac surgery or people who came with already an hospital-acquired thrombosis in the ICU before being admitted to ICU. So then they prospectively followed the patients. I highlighted that they used chart review, so it was not a confined and structured collection data set for persons for the individual center. It was more as a chart review. So the data was not at the highest quality that you expect for a prospective study. There were missing data, but they having missing values did not affect whether the study would be analyzed or not. And they used the 21 variables from the previous study. Something interesting that they did is that actually they redone this risk assessment model, which was not the intention as they presented. The intention was that to validate this risk assessment model in a different population, but they went back and actually they redid this risk assessment model. And like most of the other models, there were p-values of less than 0.1 as in the univariate analysis. Going to multivariate analysis, then the less than 0.5 was considered significant. So here they used more than 4,000 patients, and out of those, as you can see, only 2% of them, 2.5% of them, developed thrombosis. There were around 3,000 patients who had complete data. Out of those, 65% had the VTE, and as you can see, the mean age of people with the VTE was lower than the ones who were not, and it is probably for the fact that the VT in children happens most likely in the very early stages of life versus later on. And what they found that, again, here they found 7 variables in the univariate analysis that was significant. Interestingly, here the past history of autoimmune and inflammatory disease was not significant, but they found that history of cancer is now clinically relevant with a predictive importance, and also the mechanical ventilation within the 24 hours of the PICU admission. To put it in perspective and see how good a model it was, they did a area of the under the curve for association analysis. Next slide, please. And another one, and the next slide. Yeah, so what you can see at the bottom that the area under care for this new risk stratification model was 81%, and the old stratification model was 78%. So it is interesting. They basically, in terms of the predictive value, they were almost equal to each other, though some of the variables were different. So the next slide, please. So in conclusion, they said that they did an external validations of this risk assessment model, but it was not an external validation. They just redone the creation of the validation model compared to the first one. There was no really intent to have a separate population to do the external validation on those population. And here again, they identify 5 risk factors, a little bit different than the previous one, but basically either of those models, they had a reasonably good predictive value. Next slide, please. So in terms of appraisal, I gave it a May study. So the good things about this study was that really this was the largest study that was done in the pediatrics. It is a very important question for us, but as we said, it was not really external cohort. In terms of the prospectivity of the study that they studied, it was not really systematically collected as a prospective study that you have to meticulously go through specific collection of the data, and it was not. The patients could have been already on the anticoagulation or not, and that hasn't really addressed that question. And more importantly, it didn't address the risk of bleeding, so really the composite outcome was not clear. And next slide, please. So the second study, I thought that in the middle of all thrombosis, I include some hemophilia review as well. So as we all know, there has been really a revolution in the management of the patients with hemophilia, with gene therapy, novel non-factor therapies, extended half-life therapies, but really, nesoctocog alpha, which I'm going to use EFA from now on, just to not to torture you with my accent saying this complicated name, is a very novel approach to how to treat the hemophilia by really modifying the recombinant factor VIII to remove the ceiling that is imposed by the 1 Wilbraham factor in terms of limiting the extension of the half-life in these patients. In adults, their study have shown that this is very effective treatment. The half-life is really nice, and it can be given as a once-weekly treatment. But the data for the pediatrics is newer than the results in the adults. And here we are specifically going to talk about the pharmacokinetics of this in pediatrics. This study was presented by Dr. Flora Paybandy. So basically, the objective is to present the pharmacokinetics of EFA in children with severe hemophilia, and also the safety and effectiveness in the bleed protection. Next slide, please. So as I was saying, the factor VIII is being carried in the circulation by 1 Wilbraham factor. The problem with that is after some time, really the 1 Wilbraham factor is the one that would define how much the half-life would be. And with having the 1 Wilbraham factor, really you can extend the half-life of factor VIII to just so much, like a 1.5 or 2-fold, not any more than that. So the EFA intended to decouple the factor VIII from the endogenous 1 Wilbraham factor. By doing that, really allowed for the extension of the factor VIII the half-life. So in adults and also adolescents, in the Extend-1 study, you can see that on the day 3, the factor level was 46% on a 50 unit per kg dosing, and at day 7 it was 10%. So really almost half of the time these individuals will have a normal or close to normal factor levels, which is quite significant. The half-life of the study in the extent 1 trial was 41.3 hours. In extent kids trial, in a phase 3 study, it was also shown that it is well tolerated. There was no risk of inhibitor formation. It has an equivalent the side effect profile, and also it was very effective in protection against the bleed. Next slide, please. So here really the aim of the study was to define the pharmacokinetics of the IFI in children less than 12 years of age. Next slide, please. Next slide. So here they did a 2-phase in 2 groups study. The first one was in the children 6 to 12 years, and the next phase was to children less than 6 years. They were all previously treated individuals. So the dosing was the same as in adults, once weekly dose of 50 units per kg for the total of 52 weeks. And then here they measured the factor 8 activity in patients, but also they did some PK studies in 37 of the patients. Like all the PK studies, they did peak and trough levels activity in these individuals. Next slide, please. So the results, I think we can go to the next slide. It would be more kind of a more streamlined. Okay, so here you can see the basic results of this study. So as you can see, next slide. So the half-life is 38 hours in less than 6 to 12 hours in 42 hours in 6 to 12 years of age. This is can be seen with all other factor products as well. The half-life is a little bit shorter, though it's not significant here in younger children than the adults. But at the same time, the Cmax is higher in the younger children compared to the adults. And in general, the area under the curve is probably even higher in the children than adults. So quite effective and significant. Next slide, please. And here also I wanted to highlight at the bottom what we had in extent in adults and adolescents. As you can see, the Cmax was 131 and the half-life was 41.3. So very much comparable to the adult data. On the right side, you can see basically clearance of the results, and that, again, it highlights that less than 6, the half-life is slightly but not significantly lower compared to the adults. Next slide, please. So in conclusion, the PK parameter and activity in children in less than 6 years and also 6 to 12 years was quite comparable to adolescents and adults with the same dosing for the products. And it is significant because once a week dosing can offer at least quite close to the normal factor levels in half of the time and more than 10% factor levels throughout the whole 7 days. And it is an effective and safe treatment option for children. Thank you.
Okay, it's my turn now. Good evening, everyone. My name is Alfonso Iorio. I'm at McMaster University in Hamilton, treating mostly bleeding disorder patients and usually reporting about bleeding disorder news from ASH. In this case, instead, I will, as soon as I get control of the slides, report about a thrombotic condition. These are my disclosure, none really related to what I'm going to present. They are mostly institutional funding and mostly in the field of bleeding disorders. So I will try to summarize as best as I can in this very short time window the bottom line of the American Society of Hematology guidelines for thrombophilia testing. Was a very long gestation of this product. You see the authors on screen. I had the pleasure of being the methodologist for the group. I won't bother you on the methods. The same approach overall was used as described for the COVID guideline, with some specific changes to deal with a screening condition. So I don't think I need to tell anyone in this audience what thrombophilia is. We call generically thrombophilia acquired or congenital condition where the risk of VTE is increased. And you have seen how much of this evening was around calibrating, stratifying risk in patient. Now, what are the expected positives of testing for thrombophilia? Doing a better stratification of the risk of VTE, of course. And once that is done, use it to guide treatment and prevention of VTE. Of course, is a testing exercise, so there are all the risks associated with false negatives and false positive, where you may miss to assess properly the risk with the false negative, and with the false positive, you may incur in all the overdiagnosis and labeling problems. And of course, there are potential for physical, even if minimal, still an invasive blood sampling, psychological or financial harm to the patient, particularly where insurance would withdraw or deny coverage for clots to patients with thrombophilia. Now, the scope for this guideline was to provide evidence-based recommendation about whether thrombophilia testing and tailoring management based on the result of the testing improves or not patient-reported outcomes. And this, I think, is the key slide of my presentation. Then we can, go to examples. But essentially, what we did is to give a different look at how to conclude if thrombophilia testing is useful or not. So we compared the scenario where there is no thrombophilia testing, and we treat all patients irrespectively of their unknown status. And for example, we stop anticoagulation in all. This could be a provoked a clot where we stop after 3 months. What would we do if we do thrombophilia testing? Of course, we would classify the patient as having or not thrombophilia, and we would stop anticoagulation in those without and keep on anticoagulation those with thrombophilia. How would you assess if thrombophilia testing is useful? Is by comparing clots and bleeds in those treated without testing and in the sum of those put on anticoagulant, left on anticoagulant, put on anticoagulant for longer, and instead stopping, where of course you would have more or less events, both bleeding and thrombosis. This is what we aimed for in this guideline. What we consider in issuing the final recommendation is the risk of bleeding and the risk of recurrent clot, or the risk of first clot when we were in the purely preventative setting. We tried to build in also cost and burden of thrombophilia testing and anticoagulation. We didn't do a formal cost effectiveness analysis for lack of data, but we did consider ballpark figures for cost, both for treatment and for testing. And of course, we also add patient on the panel, and we consider patient preferences. Of course, if the case was for a condition where in absence of testing, you would put everyone on long-term treatment, like for example, unprovoked events, then thrombophilia testing would not be done to select those to continue, but would be done to select those to stop. And for example, here you would only continue in those tested positive, you would stop in those testing negative. You would still compare, again, risk of bleeding and recurrent clot, cost, burden, and patient preferences. Now, to apply this kind of comparison, you need to model a series of information gathered from your data. So prevalence, it is important to know how many you expect to have or have not thrombophilia, because that decides the size of these two groups and the chance for them to recur or not. The risk of incident event, essentially clots, in those or recurrent clots, in those with and without thrombophilia. To model the impact of treatment, you need to have not the relative risk of thrombophilia, but how many clots we expect in those with and without thrombophilia. You can opt for studies where these are measured and presents as incident rate, or you can have a rate in the entire population and have an association. And this association can be back translated into, you know, how many events you expect in each of the in each arm. And then we used the effect of intervention. And we didn't do a review of the evidence about the effectiveness of intervention. We took this information out of other ASH guidelines on preventing recurrences, primary prophylaxis, treatment of patients with cancer, and so on. But we applied that relative risk to those treated to assess the impact on outcomes in our model on those thrombophilia positive and or negative. In terms of the numbers we used, I'm giving you a ballpark, then the number changed slightly from one situation to another, one recommendation to another. But overall, we assumed that by testing for a panel of thrombophilias, you would find 4 patients in 10 having one of the defect. And that is because you are not testing the general population, you are testing patients with VTE. And out of the literature, these are the frequencies of defects you'll find, and you'll find in population of patients with VTE. And if you sum them up, you get in the ballpark of 40. Can be as low as 20, as high as 60. There's a racial segregation of these genes. So depending on what your setting is, these might be different. And ASH should release soon a calculator where you can actually put in the expected rate of defect in your setting and see what the benefit would be testing and or treating. The relative risk for VT recurrence, positive versus negative, is reported here and is not very different. In cases slightly lower than the one we were educated upon out of the UK and Nordic database in a previous presentation by Jameel. So this defect may increase the risk anywhere from 30% to doubling it with wide confidence interval, but this is what you have in the literature. Now, the treatment effect is a significant one. You reduce the risk of recurrence by 85%. Adopting state-of-the-art treatment, you double essentially the risk of bleeding. Bleed events are very rare, so even doubling is acceptable. But as a matter of fact, this is what happened, and you see the confidence interval there. Now, let me jump to the conclusion and then comment on a few examples. So these are the recommendations that may change. Someone says may complicate our practice. For 18 of the recommendation, the group concluded that there was no point in testing. But in 5 situations, there was evidence that testing may help risk stratifying the patient. And the first one is VTE associated with a non-surgical major transient or hormonal risk factor. So for a subject having a clot after a non-surgical major, like, you know, medical condition, or clot associated with hormonal contraception, there might be value in testing. Cerebral or splanchnic DVT in settings where anticoagulation would be discontinued. We have tested both scenarios, and there is equipoise in the literature and in guidelines around treating these cases for ever, or lifelong, or for a definite period of time. In those settings where anticoagulation would be continued forever. There's no real value in testing for thrombophilia, but where you would stop instead, you would be able to select patients at significantly higher risk. I won't provide an example, but in patients with family history of antithrombin, protein C, protein S deficiency, without personal history of clot, and consider for transient prophylaxis, say for arthroplasty, more than not being admitted to the hospital for a medical condition, or considering hormones. For these three specific thrombophilia, the risk stratification is sufficient to save enough that the panel decides was worth pursuing. Pregnant women with family history of high-risk thrombophilia for, again, primary prophylaxis. And finally, a patient with low intermediate risk of VTE and family history of VTE and cancer. Sorry, this should have been cancer patient with low intermediate risk of VTE and family history of VTE. So just to give you a taste, the manuscript is 40 pages. I'm afraid you will need to read it. But if you consider an unprovoked VTE in a 52-year-old, no past medical history, unprovoked symptomatic, for 3 months on treatment, would it be worth testing for thrombophilia? What the guidelines recommend is that in most cases, this would be indefinite antithrombotic therapy. And please consider this might be a 20-year-old. Still, the guideline would say treat him for life. What would we do with testing? We would compare what happened treating everyone with instead testing and stopping in those without thrombophilia. The recommendation is not to test. And the main reason is that when you look at the numbers, if you stop treatment in the thrombophilia negative, you still see 42 more VTE recurrences in 1,000 patients treated. It's 4%. But the panel decided that we could not take this risk and was appropriate to treat everyone instead that select patient out. On the other hand, you would save major bleeds, very small number, 4 in 1,000, or 1 in 100 major bleeds in patient at higher risk of bleeding. Still, the heavy burden here is on VTE you would let happen by withdrawing treatment in some of these patients. In making the decision, the panel used very constant threshold. So less than 5 events per 1,000 patients was considered trivial, 5 to 20 was considered small, 20 to 50 was considered moderate, which was the case I just showed you. Now, pregnancy, a young female, 33 weeks of gestation, leg DVT, today history of swelling and pain. She's, of course, started on anticoagulation, but now the question is, what do we do with this patient? Will discontinue or will test for thrombophilia and continue if positive? Guideline would currently tell that you would treat for the duration of pregnancy and puerperium or 3 months, whatever come last, and then stop. In this case, the group recommended thrombophilia testing. And the reason for that is very similar to what happened in a similar case. I'd like to show them together and then give you the number, which would be the non-surgical major transient risk factor. So this is a patient with negative past medical history, 64-year-old, simply a PRN pain medication, left leg DVT, on day 3 of admission for pneumonia. Relatively mobile, was standing up only to go to the washroom. 3 days, it's not uncommon, it's not very common either, not long needed to develop this clot, started on anticoagulation, referred to you for deciding keeping him on or stopping. Now, the treatment guideline would recommend discontinuing. The group recommended instead testing and discontinuing only in those negative, keeping the other on. And this was because by keeping both the pregnant patient and the one with the transient, you would actually save, by treating the thrombophilia positive, 20 events per 1,000 patients, which is the borderline number. And you see that the confidence interval cross the decision threshold, but the group decided on the average. You would incur a very low number of major bleeds, but we are used to take this risk in patients we put in indefinite treatment. We would save a sizable number of events. Last example I'll provide is a patient with cancer and family history of VT, stage 2 head and neck cancer, seen in clinic before starting chemotherapy, has hypertension on ramipril, and he has a brother with history of pulmonary embolism. Now, if we were to follow the cancer guideline, the prevention and treatment in patients with cancer from ASH, we would not give thromboprophylaxis, because this is a patient at low to intermediate risk, is not high risk if scored, for example, with Corona. We don't have all the elements, but let's bear with me. This is a low intermediate risk patient. What the panel tested as a strategy is instead give this patient a test for thrombophilia and treating if positive, which is what the recommendation ended in suggesting. And again, the reason is that in patient at low risk for VT, you will still have 6.8 fewer VT per 1,000 patient and 9 VT per 1,000 patient in those at intermediate risk, with a very, very marginal increase in bleeding events. You would not test all patients with cancer at low or intermediate risk. You will only test those with low intermediate risk, but family history. All of these recommendations are conditional, which means they will need to be tailored to the individual patient. And I apologize for making it so compressed. If you are willing to get more detail and you don't want to take the time reading the 38 pages, you can download from the ASH website this educational slide set that is a 50 slides. I took the one I presented out of.
Okay, great. So thank you everyone for your presentations. So we'll start with the question and answers. So first, the one I think that's for Dr. Iorio. The question is, to clarify, for patients who test positive for thrombophilia and are recommended to have indefinite anticoagulation, does this include patients who test positive for lower thrombophilia only, such as heterozygous factor V Leiden or prothrombin mutation?
So it's a very good question. And, it would have been unwild to give different recommendations for all these specific cases. We did so in family, recommendation around familial thrombophilia. And also in pregnancy, where we suggest that only antithrombin, protein C and protein S matter. And you know better than I know that not all protein C deficiencies are the same. And, not all labs are of the same level of reliability. So in general, the recommendation is about, is it worth testing? Then the question points to, let's say we find, a factor V Leiden. Do we make that enough to treat someone for life if the increase in risk is only 30%? That's a difficult question to answer. It depends very much which baseline risk you increase. You may not want to do it in a 20-year-old. You may want to do it in a 60-year-old because the baseline risk is different, decreasing risk is different. So there's no yes or no answer. For sure, you would do it in the homozygous and double mutation in a antithrombin CNS. For these two, it really depends on the overall risk of the patient.
And we have another question comment here from Minta Patel. Their comment is testing for thrombophilia and acute VTE would not be recommended, though, as a result could be skewed. Do you want to comment on that?
Absolutely. Yeah, absolutely. So the guideline took into account proper testing of thrombophilia done with a qualified lab and requested and interpreted by a clinician knowing what they do. This patient would need immediate anticoagulation in most cases, unless we are in primary prevention setting, which case you can test any day. But if you were to test for genetics, it doesn't really matter if you are in the acute phase. It would matter for antithrombin CNS. In those cases, you would, of course, take the treatment, the treatment course as needed, stop, wait 2 to 4 weeks, do the testing, and then in case decide to go back on treatment, similarly to what you would do with the dimer. But yes, you don't want to test in the acute phase.
Just waiting to see if there's any more questions. Maybe while we wait, I can ask Dr. Castellucci a question. You had talked about the difference with the lymphoma VT risk scores for primary prevention. So what is your approach to primary prevention VT in patients with lymphoma? Do you use the Corona score, or do you have an alternate approach based on what we're talking about today?
Yeah, thanks, Jameel. I think we don't often see lymphoma patients for this reason. Truthfully, we often get patients with the higher risk GI malignancies, for example, so pancreatic cancers, gastric cancers, GU cancers. That's a large population that gets referred to us from oncologists. The lymphoma patients are typically not referred to us, and I don't know if it's simply because our hematology colleagues feel comfortable addressing that aspect themselves, but from a medical oncology perspective, I think one of the barriers that we have seen is because apixaban was only recently made generic, it was quite expensive for patients who didn't have drug coverage to use this. But now that it is available in generic form, I think the decision making around this is simpler, as long as the bleeding risk is considered low to moderate in keeping with patient population. So I do use the Corona score because I think that's the best score that we have right now until more information becomes available.
Now, Lina, if I can prompt you to comment a little more on that one. I agree that the study you showed on lymphoma is still waiting for prospective validation. Even if, retrospective, if the data are well collected, might be good enough. But if you take that study as a external validation of the Corona score, which I think is fair because they recalculated Corona score on their patient, and you see AUC around 0.5, are you really trusting Corona where you see that in an external validation in that specific group of patients, it give you no more than tossing a coin?
Yeah, I know, right? Yeah, no, it is a good point for sure. And so I think that's why we don't see a lot of lymphoma patients. Maybe you're right. Maybe the hemoncs are doing that sort of assessment themselves and saying not really worth it, so won't do it. But you're right. Maybe with something a bit more tailored, it may at some point become more recognizable where there's a value to it. I think there's lots of room. When we were at ASH watching these presentations, there's so much happening with AI and risk assessment models that I think we're going to see a lot of changes in the future of how this information is applied for sure.
If anyone wants to comment, add anything else to their presentation from today?
I'm happy to give a chance to Ali if he wants to comment on. I found very interesting the data he showed on the EFA in pediatrics. How that would compare in your take was discussed at all at the presentation, how that treatment would compare with emicizumab?
Oh, yeah. So thank you, Alfonso. So, it's totally different approach to how you control the bleed in these patients. The emicizumab really has revolutionized the treatment for our children, and and right now, most of our severe patients are on emicizumab. So the question is whether this will add any new opportunity and whether there's a value that we switch from emicizumab for something like EFA. And it's a quite challenging thing, and really without any evidence of any benefit of any of this newer extended half-life, one would be hesitant to switch from emicizumab, at least with what we know now. There may come scenarios if there's a side effect in the future that we are to see, or there's an inhibitor to emicizumab development or things like that, then these are great options. But it's a really interesting time to be, really, and emicizumab really has changed how we treat, and it would be very difficult to switch from emicizumab back to something like this.
Thank you.
If there are data with really providing some exposure to factor VIII, for example, and whether constant exposure to factor VIII is beneficial, and then in terms of the effectiveness and quality of life, if they are comparable, then again, that would be an argument. But I think for now, at least, emicizumab is the treatment.
Perfect. Okay, great. Well, thank you, everyone. Let me just make sure there's no other.
I have one question for Alfonso. So thank you so much for very informative, and it is different what you said. It changes really our practice, how also in pediatrics. We are blessed with a lot of time patients come to us with the thrombophilia testing done by someone else that is not hematologist. And you went through the scenarios that you don't recommend thrombophilia to change your treatment plan. But if a patient comes with a thrombophilia, like a factor V Leiden or protein C deficiency, then how would you approach that scenario? Would you change, with knowing a person has a thrombophilia, the duration or approach you to your treatment?
So thank you for the question. Actually, it's funny because when this group was first called, we all felt, okay, what are we doing here? There's already plenty of consensus in the community not to test for thrombophilia, and it would be a waste of time for us just to do this gigantic work to end in saying there's no value in thrombophilia. And the piece that you are suggesting was actually what kept us together as a group, because we said, no, we want to explore if it changes for those with and without thrombophilia, because even if we were to say not to test, we still have plenty of patients coming to us with already a thrombophilia diagnosed. And you have to make a decision. And at that point, knowing that the positive, if treated, would have so many more bleeds or so many less recurrences is useful information for having a conversation with the patient. So I believe that you cannot, of course, the guideline is about testing versus not testing, but the calculator will be useful for someone having in front of them, a young child, more than not a patient with cancer, knowing that they have thrombophilia, put that 1.3 or 2 relative risk, give an estimate of the baseline risk, and see what they would gain if treated as opposed to not. So yes, I currently use that information. Since you asked me, I also, notwithstanding the ASH guidelines recommended for treatment, recommended not to use D-dimer-based strategies to decide if continuing or not, for patients who struggle paying for, or add a bleed. I use a D-dimer that I think is a sort of a global assessment of the thrombotic potential. If they are negative, I usually suggest staying off. If they come back positive, I say, well, your risk may be increased. Why don't we look at your numbers? So I use thrombophilia information when I have it. I have to say that it's changing my practice in terms of asking asking the test a bit more. I want to say something since you called me back. It's not a lot. If you think of how few cases of transient major risk factor associated thrombosis we see, opposed to, the unprovoked one, we would not request a ton of tests. We would just request them to rare cases where it might make a difference. We are trying to count how many we request, and we'll hopefully come back and tell you, but it's not many patients that really would fit in the indication for testing.
Perfect. Okay, great. Well, thank you. Thank you everyone for attending. I hope that was useful. And thank you to all our speakers. There was that link there before to Valerie's program. That'd be great. If you do like what Thrombosis Canada does, then consider donating to Thrombosis Canada. Thanks. That's everything. Thank you, everyone.
Thank you, everybody.
Good evening.
Thank you. Good night.